The other interesting thing that people often say about these services is, yeah, but they're highly selected. You've just cherry-picked, that old phrase, they've just cherry-picked the fit patients that have got really supportive families. Actually, in one of our services in particular, in our Birmingham service, they have 85% of the people on that service are over 75 years of age. So they're complex elderly, but they're still appropriate for these services if you get the right support infrastructure sitting around them. So we engage with a wide range of services. Sometimes it's the little things that make people uncomfortable, the small things that you can fix for them at home. Sometimes it's big deterioration in their condition. And this is one of our family liaison coordinators talking about our end-of-life service. So it's about focusing on what makes a difference to the patients and then overlaying our professional expertise, whether that's from a social work perspective or a clinical nurse specialist perspective, what makes a difference to them, not what makes a difference to us. So it's common sense, as I keep saying, it absolutely is common sense. One-to-one safe clinical care at home, it's got to be about being safe. Thorough research into the availability and eligibility of other services in the locality. So about 200, some of our services, we have about 200 people who are on the list of providers, those directory of services, and we'll make sure that patients get access to the most appropriate support services to get the right clinical and patient-reported outcome. So sometimes we'll provide care ourselves, more often we'll signpost people to the appropriate care, and it could be anything from needing complex chemotherapy by a clinical nurse specialist to someone to walk your dog. And why we've been successful, I think, is just not saying we're only a healthcare provider. What we're trying to deliver is an outcome here. So it doesn't matter, actually, what input. The inputs are largely irrelevant. It's focusing on what you need to get to as an output. This 24/7 support's really important. 3 o'clock in the morning, people get scared. They don't know what to do or how to manage the particular crisis they may be in. Or it might just be a worry. They don't know when their next outpatient appointment is. If they can phone a 24-hour support line who knows about them, can see their care plan, can link into both their primary and secondary care record, actually you can avoid many, many hospital admissions by that service sitting around the patient. Yep, I'm on my last slide, so that's good.
Perfect, thank you.
So the bit that is about us and not them, it's about how we can work together as providers to align so we make sure that we think about the outcomes, not about how we think about our own organisation or our own organisational needs. It's about aligning ourselves as a group of providers around the patients. And the incentives are all in the wrong place currently. Mostly acute trusts don't mind lots of people going to hospital and going in because they get paid every time somebody crosses the threshold, and we need to really change those incentives, otherwise how it is now will continue to be.